We often wonder what future generations will think about our time, the circumstances that befell us, and how our actions shape the world of tomorrow. Our society has faced a global pandemic on a scale not seen in over a century. Problems many in the United States thought existed only in far-off places quickly found their way to our doorstep. Countless challenges have emerged. For every question we answer, yet another presents itself. Many of these struggles are the culmination of decades of global health issues. And as we continue to address them, we begin to realize just how connected our world truly is.
Everyone knows how much everything has changed, not just in global health, but in every aspect of life since the beginning of this pandemic. You can't just isolate yourself from the rest of the world. It doesn't work. Half the world still doesn't have access to quality health care, and probably 75% of the world doesn't have access to modern surgical care. I get restless because there's so much to do, and you feel like the clock is ticking and there's only so much time.
Improving healthcare to build a better world. This is the prime directive of the doctors, scientists, and researchers of the Robert J. Havey Institute for Global Health.
We've grown considerably. We have 9 different centers, and we have one global program. So we've got basically 10 entities involved now, from surgery, primary care, oncology, cardiovascular disease, emerging infectious diseases, health policy, you name it. It's really become a very broad program.
Peru, Bolivia, and Pakistan, though separated by thousands of miles, they share one critical issue. All are severely under-resourced in the field of genetic sequencing. In fact, only 2% of all worldwide COVID gene sequencing comes from samples gathered in South America. This creates a broad gap in knowledge, risking emergence of pathogens that could spread broadly long before detection.
Depending on the project, depending on the question, there's a lot of different things we can do with those sequences. One of the big things we do with SARS-CoV-2 is that's how we determine what the lineages are or what the variants of SARS-CoV-2 are.
Due to a lack of equipment or personnel, data that shapes public policy and healthcare research is underrepresented for these populations.
We have labs set up to handle these kinds of specimens. This is not necessarily an easy process, but it is something that we have a lot of experience with, and we have a lot of the resources to do. A lot of these resources that we take for granted or that are readily available to us can be harder to find in some of these countries.
It's in these 3 countries that we are building sites to enhance the capacity for obtaining and, importantly, processing these samples. This will help fill in critical gaps about the structure of microorganisms among their populations.
As part of this project, we'll be training for laboratory technicians and bioinformaticians that are in these places to start to learn how to use these newer resources in order to allow them to start sequencing and surveillance of SARS-CoV-2 and other pathogens within these locations. The experience that the Institute has, the connections that it has, and throughout these different locations and countries, it just opens a lot of doors and moves things a lot faster than they would be that if we were trying to start from scratch.
Part of our efforts to understand and combat healthcare disparities relies on building novel solutions to address those challenges. Collecting genetic samples can be difficult due to distance or other barriers, but at-home testing can be less accurate and effective.
The primary method of transmission of SARS-CoV-2 is on breath. All of the COVID tests that we take involve swabs in the nose or in the throat, but they don't tell you whether you're exhaling it.
A prototype collection device, repurposing already available materials, will help researchers more readily obtain those samples.
We're able to build a small device that we ended up calling the EBCD, the Exhaled Breath Collection Device. In the course of working on this device and this sampling method for COVID-19, it became apparent that it could be useful in other respiratory viral diagnostics and perhaps any other pathogen that would appear in the breath.
Accurate testing and cataloging of information is critical to combating large-scale health issues. What we do with that information is the key to alleviating catastrophic outcomes. A COVID surveillance program at Northwestern has been a key tool for understanding the state of the pandemic and possibly predicting its next move.
So surveillance is looking at how many people are dying every day, how many people are catching COVID every day. Surveillance is always a great proxy that you have a problem. But the problem with surveillance, it doesn't really tell you what's going to happen next.
We have some more advanced surveillance metrics that go beyond the traditional measures that are retrospective. We can, in an ongoing basis, track where we predict the case level is along the epidemiological curve, whether we expect an acceleration in cases to continue, or if we have reached the apex of an outbreak and we expect cases to start to decelerate.
With support from IGH's first ever Global Innovation Challenge Award, the COVID surveillance program is generating critical information about the current state and future of COVID-19.
This interdisciplinary team that was able to examine topics in ways that we could not on our own separately. So that part of the research that we engage in, I think, has the potential to inform not just this pandemic, but future pandemics.
In Colombia, the IGH is building a center for the study of a fast-rising medical concern. Present around the world, but underrepresented in research among lower-income countries, the long-term effects of COVID-19.
On the way back, can you walk heel to toe on the straight line?
We can see, we have the resources in America to see how this has affected the community, what the symptoms are, what's the percentage. We don't have that in South America. We don't have those numbers in third world countries.
In addition to our Colombia location, another long COVID clinic is being established in Nigeria. In building these types of research programs around the world, we aren't just treating an existing healthcare concern. We are laying the foundation for combating future issues and bolstering our continued support for these communities for the long term. The Institute's Center for Global Oncology has continued its work throughout the pandemic. Dr. Li Feng Hao has been working on oral and cervical cancers caused by HPV. The HPV virus is responsible for 100% of the 600,000 cervical cancers occurring every year around the world, 90% of anal cancers, and 70% of cancers of the tongue and tonsils. Collaborating with partner sites in Africa, where HPV is highly prevalent, she is working to detect a blood or swab biomarker, which can detect these HPV cancers at their earliest stage, allowing more effective treatment and saving lives.
Current challenge for put the oral cancer under control is the early detection. Unlike other cancers, we still don't have a system to systematically screen oral cancer patients at their early stage.
The study of epigenetics, which are genetic variations that can result from external factors, is a key component both in the study of these oral cancers and for a wide range of healthcare issues.
So our focus is to study epigenetic biomarkers to see if these biomarkers can serve as early detection tools to screen those who have high-risk HPV infection.
Our global health education work, a foundation of the Institute from its earliest days as the Global Health Initiative, continues as we introduce medical students to working with populations in low and middle-income countries. Although student travel was limited at the height of the pandemic, our medical students are traveling again, learning lessons about healthcare and doctoring that can't be gained here at home. A major barrier for healthcare in many rural settings is a deficit of basic resources for running medical equipment.
When we travel to very rural villages, electricity is not something that we see regularly. Anyone who comes in with a diagnosis or symptoms suggestive of a respiratory illness, we don't even have the capability of doing a chest x-ray.
In Belize, we worked with local educators to train health providers on use of a portable ultrasound machine for diagnosing a variety of medical conditions. The device is a powerful tool for bringing advanced treatment to areas facing resource struggles.
This ultrasound device, it can be used for a variety of different conditions and diagnoses. We hope to utilize the ultrasound machine to be able to diagnose more effectively pneumonias and whether or not people need antibiotics for those things. The goal of these things are not just to bring something or bring a provider for a short time period and then leave and then not really have any kind of sustainability to it.
Access to surgical treatment is another area of disparity in global healthcare. Our efforts to train local surgeons and provide equipment are helping to close that long-standing gap.
In order for us to teach skills, both basic surgical skills and then there's more advanced surgical skills, the endpoint is very much to really support local systems and local providers to enhance their capacity to provide care for their own populations. It's not a parachute in kind of a model. It's very much a sustainable model with long-term partnerships.
Before the onset of war in Ukraine, we worked to train local surgeons on techniques to lower infection after surgery, a common problem in the area.
One part of it was the processes themselves. We came up with a list of things that were kind of, easily doable and probably would have a significant impact. A lot of the instruments are old and not a great quality, and they don't have a great process of how to keep an eye on them. We started seeing the differences pretty much right away in the quality of the instrument, what they can do, and it was less crushing and less time.
With the approaches we're taking now, not only can we help people, but we can improve the capacity in these countries for people to identify their own problems and tackle their own problems themselves.
We're past the days of dropping into a vulnerable area, providing a little help for a week and then leaving. We're long past those days. We know that's not sustainable. It doesn't fix anything. It's a nice thing to do, but it doesn't solve the problems.
Instead of bringing our solutions to them, they're going to develop their own solutions that are appropriate for their setting.
In Mali, diagnosis of tuberculosis still suffers from access to and processing of patient samples. Often, it takes far too long to give a patient a diagnosis, further exacerbating the damage of this long-standing disease.
It often takes weeks in that case. And I would say, I think the longest that I've heard is probably 3 weeks. And that's from issues with both getting out there to collect the sample, getting it to somewhere where it can be safely processed.
Funding from Institute grants is supporting a prototype device that automatically prepares samples on site and utilizes smartphones to scan and share sample data.
So this is an automated smartphone microscope with 2 components. The first one is an automated scanner so that the staining can be in a more accurate way, in a more faster way.
This staining procedure is common for different types of samples, everything from mucus to tissue samples.
The second component is the smartphone microscope. So it has connectivity, so that's allow for telemedicine. So pictures can be taken from slide, sent to expert, to anywhere in the world to get more accurate diagnostic.
And so the device really brings it down to under about 3 hours from collecting, smear, and then reading it under a microscope.
Not only is the device potentially transformative for the diagnosis of TB, It is being developed to best support local partners in these settings and the logistical challenges they face. These solutions are made possible only by the dedication, resourcefulness, and determination of our teams. They have committed themselves to building a more equitable future for this and future generations.
We need to inspire everyone who's thinking of a career in the health sciences or in medical care or as a physician that the work is worth doing. Just like we can't take for granted that the rest of the world will fix itself, we can't take for granted that the kind of doctoring we have in the U.S. and the kind of doctoring everyone really wants for themselves is just going to happen. The problem is that the more we do, the more you see needs to be done. We've got to build the planet for the next 100 years. 100 years sounds like a long time, and yet it doesn't sound like that long anymore. Our children, our grandchildren, our great-grandchildren, they're going to live here. We have a responsibility. They are going to live here. They've got to get up every day and do what we want to do, and we've got to build a world so they can do that. And that does motivate everyone in this institute every day.
Thanks to the support of the Institute's partners, the ceiling for human potential around the world has never been higher. We continue to support the tireless efforts of our doctors and scientists. We celebrate the successes we have achieved together. And inspired by the promise of a brighter future, our goal is as resolute as it has ever been. Ensuring good health for every human being.